Good afternoon, and thank you for the invitation. So I will start my talk by giving you a little bit of history on the lung transplant and how exponentially it has grown. As you can see, the lung transplant started in the mid-80s and has continued to grow. The purple section of the bars that you see is the bilateral lung transplant, and the green section is the single lung transplant. And as you can see, the number of bilateral lung transplants are growing a lot more, and the indications as well as the reason to do the single lung transplant is getting less. And I will explain to you why, because there's a difference in survival also when we do bilateral lung transplant versus the single lung transplant. So can we move to my next slide, please? So this is the center volume in US as well as the rest of the Western world, which is published by the Society of Heart Lung Transplant. And as you can see, the majority of the centers perform somewhere between 10 and 30 lung transplants. There are very few centers that perform more than 50 transplants, but because their volume is so high, those centers usually are overwhelming. And there are very few centers that perform less than 10 transplants. Can I have my next slide, please? And this is the slide that shows us how the outcome of the lung transplant depends on the volume of the patients that get transplanted in different centers. And as you can see, the volume does affect the outcome. The smaller the volume, usually the outcome is not good. That's okay. You can move to my next slide. This slide tells us about the indications of lung transplant all over the world. And the brown bar is the one that is of your area of interest, which is IIP, or interstitial idiopathic interstitial pneumonitis, as well as the small yellow bar, which is ILD, which is not IIP. In the early era of the transplant, as you can see on the left side of the slide, which is green, COPD was overwhelmingly majority number of transplants that were being performed. But as the time is passing by, the number of patients that require lung transplant for idiopathic interstitial pneumonitis has grown. And it's almost a third of the patients nowadays all over the world, or sometimes even up to 50% that require lung transplant due to idiopathic interstitial pneumonitis. Can I have my next slide, please? This is a slide from my previous tenure in King Faisal Specialist Hospital. And on the left side of the slide, you will see this pie bar. And in King Faisal, which probably represents population-wise or demographics of the population-wise, very close to area of Pakistan, you can see that at least half of the patients that underwent lung transplant had interstitial lung disease as their underlying diagnosis, as opposed to the Western world, where about a third of the patients still require lung transplant due to idiopathic interstitial pneumonitis. Next slide, please. So now we will go to the indications for the lung transplant, which are common for all the diseases, including interstitial lung diseases. And this is a generic way of describing the indications for lung transplant. You have to have an untreatable end-stage pulmonary.
Dr. Imran Nizami, can you please speak louder, please?
Yes. This slide is showing the indications of lung transplant, and this is a very generic slide which shows the indications for lung transplant for all the lung diseases. The primary focus on is that the disease that we're subjecting. Can you hear me now? Hello?
Yes, sir, we can hear you.
Okay. So the disease for which we are offering the lung transplant has to be untreatable end-stage pulmonary, parenchymal, or vascular disease. And as you may have already heard from your previous speakers, that the interstitial lung diseases are also quite dynamic these days, and newer medications are being offered. So once all those medications have failed, that's when we consider patients for lung transplant. There should be absence of any other major medical illness and the substantial limitation of the daily activities. We usually describe that as New York Heart 3 or more dyspnea. And the projected life expectancy should be less than 2 years. They should have rehabilitation potential. You know, sometimes these ILD patients are extremely myopathic and weak, and then uh, we we cannot accept them for lung transplant unless they have shown some improvement in their rehabilitation potential. They should have a they should have a satisfactory social or psychological status and appropriate nutritional status. A BMI of more than 35 is an absolute contraindication for lung transplant. Can I have my next slide, please? So how do we determine the life expectancy of the patients that get referred to the lung transplant? And in this regard, I wanted to just show you the criteria that have been described in the literature to judge the life expectancy of the patients with idiopathic pulmonary fibrosis in particular. If their baseline DLCO is less than 40% predicted, if they desaturate to less than 80%, 88% during their 6-minute walk, and the extent of honeycombing that is seen on high resolution CT scan and the presence of pulmonary hypertension determine their survival. And if you're following these patients longitudinally and you've noticed that their level of dyspnea is increasing or their forced vital capacity has decreased by more than 10% from their absolute baseline, and the diffusion capacity has reduced by greater than 15% from their baseline, or there's worsening of the fibrosis, those also tell you that their prognosis or the mortality will be high. The timing for referral for the lung transplant for interstitial lung diseases, if you have histologically or radiological evidence of UIP, the reported survival used to be 2.5 to 3.5, but nowadays you have all these newer medications. So this criteria is more likely to have changed. However, we still suggest that you start considering lung transplant in patients that have UIP-like picture as opposed to the NSIP. If they have a forced vital capacity of less than 80% or the diffusion capacity of less than 40% predicted, you should start thinking of the lung transplant. We often don't recommend these days to refer these patients right away to the lung transplant because of the newer medications. I think those medications should be tried first. And if these numbers don't change or continue to decline, that's when you refer them for the lung transplant. Any oxygen requirement, even if during the exercise. However, for the inflammatory interstitial lung diseases, especially the ones that are related to the autoimmune diseases, they have to be tried to the maximum with their autoimmune treatment before they get referred to the lung transplant. Next slide, please. Now, timing for listing is also becoming relatively moving target. In the earlier era, if we see these criteria like their FVC has dropped by more than 10% in 6 months, we would consider it for them for the lung transplant. However, we individualize these patients, and some of these patients do stabilize with the use of the newer medications. In that case, we follow them longitudinally in our clinic. Despite that, if their 6-minute walk distance remains less than 250 meters, we consider them for the lung transplant, and especially if they have developed associated pulmonary hypertension based on echocardiogram or right heart catheterization, we consider them for listing for lung transplantation. Next slide, please. Now, some of the common contraindications for considering these patients for lung transplant, if they have had any malignancy in the last 2 years, with the exception of skin carcinomas, we don't consider them for transplant. If they have any untreatable advanced dysfunction of any other major organ. For example, if they have renal dysfunction or liver disease, we don't consider them for transplant. Right heart failure is not considered a contraindication because it gets better if you do the transplant. If they have non-curable chronic extrapulmonary infections like hepatitis B, hepatitis C, and HIV, they're not considered for transplant. However, you will find exceptions in the literature where there are now transplanting patients with HIV disease that have undetectable viral load. Similarly, HCV is a curable disease now, and they can be considered for transplant. If they have significant kyphoscoliosis, they don't get considered for transplant. If they are non-compliant to the treatment by their previous records, they're not considered for the transplant. If they have untreatable psychological condition, they're not considered for transplant. And especially if they don't have a reliable social support system, because transplant is a very big undertaking. It's like trading one disease from another disease, and they require a very strong social support system as well as a caregiver that will be with them all the time after the transplant to provide them with appropriate uh, help. So if they don't have a special social support system, we don't consider them for transplant. If they have substance addiction or if their BMI is more than 35, we don't consider them for transplant. I think I can skip this slide because we probably not going to go through those. Yes, one modality that we often use for our patients while they're waiting for the transplant, especially if they have interstitial lung disease, is an ECMO. As you may have noticed that many of your patients, once they get to the advanced disease, they become so severely hypoxemic that you cannot maintain their oxygenation even with the high flow oxygen. Putting them on the ventilator usually does not work because their lungs are so stiff that you may not be able to ventilate them even if you put them on the ventilator. So the modality that we use very not infrequently in these patients, if they get worse while they're on the lung transplant waiting list, is ECMO. ECMO is extracorporeal membrane oxygenation, where we take their blood out and circulate it through the machine, which performs the function of gas exchange, and we put the blood back into their circulation. Next slide, please. ECMO in the lung transplant patients is used, as I mentioned, if they have respiratory failure, and sometimes if they have combined uh, interstitial lung disease and advanced pulmonary hypertension, then they also have not only respiratory failure, but a circulatory failure also. And that determines whether we use a veno-venous ECMO or veno-arterial ECMO. Next slide, please. Yeah. This is an example of the ECMO that is that we use a double lumen catheter placed in the neck. It's a kind of VV ECMO by the use of Avalon cannula. Next slide. With this, the advantage is that we can extubate the patients and rehabilitate the patients while they're waiting for the lung transplant so they don't get severely deconditioned. Next slide, please. Some of the complications that we encounter in our patients after the lung transplant, with whether they have interstitial lung disease or any other lung disease, is early graft dysfunction, infections, anastomotic complications, or acute rejection. Now, this is the example of an early graft failure. Sometimes the patients come out of the OR and you will think by looking at this chest x-ray that we did not replace their lungs, we just left their fibrotic lungs in there because they're still looking completely whited out. But these are new set of lungs that have developed primary graft or early graft failure. Next slide. When we see this kind of scenario, we have to think about certain common things like volume overload, venous anastomotic obstruction, hyperacute rejection, a, which is kind of overrated and we have almost never seen it, and as well as the primary graft dysfunction. Next slide. This is a slide that will help you understand how the venous anastomosis is done. A patch of the left atrium is taken out, and the two pulmonary veins that are taken out of the donut connected to the left atrium are then patched in. So sometimes a clot forms in that area, which causes venous anastomotic obstruction, which leads to whited out lungs. Next slide, please. Next, venous anastomotic obstruction was a surgical emergency, and we usually send these patients back to the OR to fix this. The diagnosis is done by the transesophageal echocardiogram. Next slide, please. The primary graft dysfunction is a term that we use for the acute lung injury like pattern when we have excluded all the other possibilities of whitened out lungs like fluid overload, anastomotic obstruction, infection, and hyperacute rejection. And whenever we see that, there is an increased risk of chronic lung allograft dysfunction. The treatment of this condition is really just the symptomatic, and it's graded just like you grade your ARDS. It's okay for next slide. It's graded just like grade your ARDS patients based on the PF ratio of more than 300, absent primary graft dysfunction, PF ratio of between 200 to 300, it's present, grade 2 and then grade 3. Next slide, please. Now, if on the left side of the slide is the X-ray of the same patient that I showed you in the very early part with the primary graft dysfunction and whited out lung. We only supported these patients with, ECMO and prevented development of any infection or rejection. And a couple months later, we had this X-ray, which is completely normal. So it's a potentially reversible condition, and the only treatment we have for this condition is supportive. Next slide. Some of the airway complications that we see are ischemia and necrosis, dehiscence, which is very rare, and bronchomalacia. In this slide, you will see necrosis of the right anastomosis. This patient has undergone right single lung transplant and unfortunately has developed some necrosis of the right anastomosis. Usually, this necrosis is very superficial, and this mucosa sloughs off, and the patient gets better. Next slide. This is the scenario we don't want to see when we have a patient that developed necrosis followed by the dehiscence. When this happens, the only option we have is to retransplant these patients. Next slide. Bronchomalacia is not uncommon at the site of anastomosis, and when this happens, we can treat it by placing a permanent stent in that area. Next slide. Acute rejection is a fairly common condition, and about a third of the patient will experience some degree of acute rejection during their lifetime. Whenever the patients hear about acute rejection, they get scared, but it's not really, it's a treatable condition. It can happen as early as 3 days post-transplantation. And in the later part of the transplant, when we follow these patients very closely, we even send them home with a home spirometer so they can check their FEV1 on a regular basis. If they notice that their FEV1 has dropped to more than 10%, that's an indication that they might be experiencing lung rejection. We bring them to the hospital, we perform a bronchoscopy and a transbronchial biopsy. The only way to confirm the diagnosis of acute rejection is by performing transbronchial lung biopsy. Radiograph is often normal, and after the transbronchial biopsy, if we diagnose the acute rejection, then we provide them with the treatment. And these are different grades of acute rejection that you're seeing. What we ask our pathologist to look at is the small blood vessels. And around the small blood vessels, if we see a very thin layer of lymphocytes, which are blue dots, we call it A1 rejection. If we can see these lymphocytes under the low power microscope, then we call it A2. When this starts going into the interstitium, we call it A3. And hardly ever we see this A4 where we start seeing the infarction of the lung. Next slide. This slide basically telling us that about a third of the patients within the first year of the transplant experience acute rejection. And like I said, we follow these patients very closely with their spirometries, not only at home, but in our clinics also. And whenever we have a suspicion of acute rejection, we perform a transbronchial lung biopsy. Ideally, we should have at least 5 alveolated pieces of the lungs to be able to identify acute rejection. So we usually take about 10 transbronchial lung biopsies each time we biopsy these patients and hope that at least 5 of them will have alveoli, because we need to see these small capillaries that get surrounded by the lymphocytes to diagnose acute rejection. Next slide. This is the slide that uh, shows us the survival of the lung transplant. The lung transplant is, like I said, is trading one condition to another condition, so it's not without the problems. And about 40% of the patients can die within 5 years of the lung transplant due to different medical complications, including chronic lung allograft dysfunction and different infections. Idiopathic interstitial pneumonitis seems to have slightly better prognosis in this particular slide, about 6.2 years of the median survival. Next. Um, this slide, as I mentioned in the very early part of my talk, that the number of bilateral lung transplants are progressively increasing as compared to the single lung transplant. Now, for idiopathic pulmonary fibrosis, single lung transplant will work just fine, and uh, they will survive and they will have a decent lifestyle. But the survival for the bilateral lung transplant is a lot more than the survival of the single lung transplant. Therefore, more and more centers are now opting to offer bilateral lung transplant for patients with idiopathic pulmonary fibrosis, especially if they are of a younger age. Next slide. Now, this is my uh, prize and joy. This is my very first patient when I joined my tenure in Oklahoma in 2001. She had interstitial lung disease of a very unusual type. She was a jewelry maker, and she developed interstitial lung disease from the dust that she was exposed to while grinding that jewelry. She was turned down from all the centers around and basically told to go to hospice and die in 2001. We took our chance and we transplanted her, and I saw her recently in my clinic 22 years later, healthy, smiling, and really made our line of work worth it. So with this brief talk, I would like to stop. And I think this is another of my patient, which is interstitial lung disease. Now he likes to swim with the sharks in ocean and all that, which is not something we recommend. So I will stop here, and I will uh, I'd be happy to take any questions if now, or we can do those later. Yeah, we can stop the slides.
Thank you, Dr. Nizami, for a wonderful talk and great opportunity to learn from you. आपसे questions हैं डॉक्टर निजामी. एक ये आपने सऊदी अरेबिया डेटा को दिखाया in comparison with Western data, and you showed that at least 50% the lung transplant at King Faisal Research Center was due to ILD. So what type of ILD was more common over there? Was it IPF or hypersensitivity pneumonitis? And my second question to you is that do you prefer heart lung transplant in patients who have concomitant pulmonary hypertension, or there's no data about it?
Well, the first question, the Saudi population apparently is genetically very different. As you saw, we had very, very few patients that required lung transplant due to emphysema. Those patients smoke like chimney, and they start smoking at the age of 12, but for some reason they're genetically protected from developing end-stage emphysema. Similarly, interstitial lung disease that we saw was idiopathic variety, not always UIP pattern, but sometimes we had transplanted patients as young as 14 and 16 years of age because of end-stage lung disease. So most of them were idiopathic interstitial pneumonitis, but not all of them were of the UIP variety. The second question that you had the heart-lung transplant, hardly anybody over the world now performs heart-lung transplant because we know that once we replace the lungs, the pulmonary vascular resistance will be normal. And once the pulmonary vascular resistance becomes normal, no matter how bad the right ventricle looks on echocardiogram, it recovers. It takes time, but it recovers back to normal. So hardly ever you will see heart and lung transplant. You can count them on your fingers all over the world how many heart and lung combined transplants are being performed these days.
Any other questions?
Traditionally, we used to hear that.
Mm.
Hi there, Jazakallah khaira. So traditionally, we used to train and get ourselves trained about the fact that anyone who is above the age of 60 should be not refer for lung transplant. Is there a cutoff like this now, or has been a bit more like relaxed about it? What is the normal
Yeah, it's
recommendation?
we call it a physiological age, and physiological age of 65 is still considered by some as a contraindication. But the last transplant we did in Oklahoma was 73 years old, and we have a referral for a 75 years old. If they look like they are 65 or 60, we will consider them for transplant as long as their body habitus as well as their muscle strength and other organ systems are good. So it's becoming more and more flexible, and especially with the interstitial lung diseases, you will see in the literature that majority of the patients that are getting transplanted are actually above 65 years of age. So it's no longer age alone is no longer a contraindication.
Assalamu alaikum, sir. My question is that what is an average survival rate of a lung transplant recipient?
40% of them survive for 5 years. 60% of them survive for 5 years. 40% of them can die within 5 years due to different complications. Now, after 5 years, it's like I showed you my own patient. She's 22 years post-transplant and she's still alive. So we can only give you a median survival based on the statistics. So whenever we talk to a patient, we give them this information that you have a 40% risk of dying within 5 years of the operation.